our seats again. So the next request to speak is Mr. Jones.
Yeah, thank you, Mr. Chair. My iPad is locked. So I'm going to chart
There went his questions.
that I was looking at, but it's the, I don't know what, okay, yeah. Thank you. Yeah, I'm going back to the chart, the page 711 of the report. And what triggered an additional question is, I heard a response to the question about the $3,000 that has been there forever. But then I started looking at the shaded areas versus the white areas, and I'm thinking, well, are the shaded areas where the changes are? And if that's the case, then the $3,000 for PERS care, is that a change?
Yes, that's correct. What we did is we looked at that 90-10 benefit and the value of that versus the 80-20. So the benefit in the care is a richer benefit, and so between we increased that from 2,000 to 3,000.
So that is an increase then?
Yes.
Okay, and so then that drives the next question, looking up at the deductibles where you have the PERS care and the PERS select. Those are changes also.
Correct.
And what were those numbers?
They were all, if you look at that original slide, they were all 500 and 1,000. So we've left the choice at where it is, and then we made actuarially equivalent to the 90-10 benefit to the choice, so that increased the deductible from 500, 1,000 to 750 and 1,500, and increased the coinsurance from 2,000 to 3,000, and that actually equilibrates the benefit design of the richer care plan to the choice plan.
So if I look at the select then, if the individual 1,000 and family 2,000, that's an increase.
Correct.
And then right below that, after the increase, then you get a deduction. So the net effect on the member is
What it is today. If you do your 5 incentive credits, it takes it from 1,000 to 500, and that's where it is for the single plan.
Yeah, but why we go through that process if the numbers, I mean, in order to get to the same number, you got to go through this additional process. And I understand the care part of it, but it seems that we're using numbers to drive change as opposed to just care.
I think I think that's a really good question. The idea is to create a program that aligns and engages both physicians and members, and that's why the idea is that create an opportunity for members to engage and reduce the deductible. We hear, and just like what I was speaking earlier about, it's hard to, and I know people are busy, but it's hard to engage members in their care. And so this really creates an incentive to do it. And the reason why it's in the deductible is because CalPERS is a trust. This is a good vehicle for you to be able to do that. You know.
Yes, and you know, I always look at also the fact of what's the impact on individual members, especially our retirees, who on average, I don't know, maybe $3,600 a month in retirement. That's a fixed income. So I always look at what's the impact on those individuals. And that's why I always ask, what's the impact on an individual, so that we could assess that impact. So perhaps when you come back, Mr. Chair, if we could run a scenario to see what's the impact on a member for these changes.
Very well. Anything else, Mr. Jones?
Yeah.
Okay, Ms. Motter?
Thank you. A couple of points. One is that I think these proposed PPO changes, they're combining two things. One is this VBID proposal, which is the PERS Select proposal, and the other is a rationalization between the PERS Choice and PERS Care to ensure that they're more actuarially equivalent offerings. Is that correct?
Yes, correct.
So I don't want to confuse the two, that a decision on one does not necessitate a decision on the other.
That's correct.
The other thing I wanted to just follow up on was, Dr. Clapper, you mentioned that some purchasers will offer, let's say, 4 free PCP visits. Did we look at that in this for this VBID, and did we do any analysis or assessment around what the cost or benefit of that might be? It's an intriguing idea. So
I think we did talk about it, and I think we were worried about confusion. This seemed cleaner to the point of, keeping how they already have to earn 5, work on engaging around 5 things, that this kept it really clean. You don't have to say, did I use it up? I didn't use it. Oh, that visit was a preventive visit, under ACA or not. This just made it $10. It's simple to understand. If I choose a doctor, I pay $10.
And did you find in other programs where it's been offered, did you find confusion occurred? Did you have any way of gauging that? Maybe?
I didn't really have a good way of gauging it, but
Okay.
I think that someone has to be tracking it, and there causes confusion that way. So this seemed really simple and clean.
Right. Okay. All right. Thank you.
Thank you. Ms. Brown?
Thank you. Hi. So I appreciate Mr. Jones pointing out that the changes are highlighted in gray, so that's great for me as someone who's not been on this, that's not on this committee. But I do have a question with respect to the savings. I know another committee member said, well, there's going to be anticipated $46 million in savings. And so those savings goes to CalPERS, but that means the increases, though, go to the members, and I'm not sure if that's a good trade-off.
Actually, the savings go to the employer and the employee through the reduction in the premiums. So there's going to be reduction if premiums differ between the plans. So if the members choose to go to the select product, they do save in their premiums.
But let's say I'm a PERS Care member. I don't have an option to do the 5 little things to get my my deductibles reduced. Is that correct?
That's correct, for keeping the plan designs for PERS Choice and PERS Care.
So what would the savings be if we did offer them? I mean, what if we didn't go, when I look at the areas that are in gray, why wouldn't we offer the PERS Care people the incentive so they could get their deductibles down and then keep their urgent care and specialized visits at $35? How does that impact the savings? Because really what we're talking about is increasing cost to our retirees.
We can bring back some figures to show what the premium savings might be in these designs, because these designs are pretty much the same, especially with Care and Choice, as they are today. Now, when we work with the premium, however, and if we have a member that chooses to leave care and go to the new Select VBID, they're going to have a reduction in their premium. They will save money in terms of their premium, as will the employer.
Except they have to go to 80/20 from 90/10. Is that correct?
Correct. That's how it's designed. And it has been actually since the 80s and the 90s.
I'm just looking for an opportunity to have people who want to stay on PERS Care at 90/10 and give them the option, because you're talking about getting people to work with a primary care physician and basically do the biometric testing and do all those things. So why can't we offer that also for the PERS Care? I'm sure you'll still have savings, and that way the costs aren't all put back on the members.
We designed the VBID really as a pilot. This is the first time we've had the opportunity to do something different than just have coinsurance and copays. We actually this approach is a carrot approach versus other plans that we presented a year or so ago, like Connecticut and like Minnesota, where there were stick incentives, especially with the Moms and Babies program. There are ideas in the health plan world that you penalize mothers for C-sections if they're elective. We prefer not to try to do that. We think that, as Dr. Laura said, get the new moms and babies engaged and waive that 20% deductible. And that is we believe, under the value approach, a positive incentive like that is and I think that this committee that's been their direction for all the years I've been talking to this committee, that it's really incentives for positive behavior change rather than negative incentives for what you want to be positive change.
And Ms. Brown, I also wanted, I know Ms. Mather had pointed it out, I think sometimes we have confused the committee because really there is two things going on in this agenda item. One is the PPO, which PERS Choice, PERS Care, and then also talking about a pilot for VBID, and we're all kind of commingling it. So one thing is none of these have been changed in 10 years. As such, PERS Care is a 90-10 plan, which is a much richer plan. Actuarially, regardless if we did VBID or not, we needed to increase the deductible to be actuarially sound. So that put to the side, we do want to do a pilot with the PERS Select. We believe in promoting value. If that is successful, I see that we would potentially look at, rolling that out to the other PPOs. But I think we've done a disservice is because I think we've commingled two different topics, and it makes it look like we could almost take all the PERS Select design and spread it across all the PPOs, when that really has not been the focus for the last 2 years. It really has been just on PERS Select.
Thank you.
Yes. All right, Mr. Miller.
Yeah, I just want to reiterate that I really do like, and it's music to my ears, the incentives for PCP enrollment, that type of piloting, that type of approach. But I guess what I'm having a hard time kind of sussing out here is the basic idea is when we do that stuff, the primary focus is better health outcomes. But it just also happens to be something that will generate savings that predominantly fall to the employer just because of kind of the split of things. And I'm trying to sort out with the PERS Select that's being proposed, the increases to the deductibles as juxtaposed to the incentives to reduce those deductibles. It almost seems like we're kind of hedging here. If we really believe that those incentives to enroll and that will generate cost savings, why would we need to increase those deductibles? What portion of that would relate to that versus trying to drive premiums down? I'm just not seeing how the moving pieces relate from what our financial expectations of these changes will be. It seems a little like we're raising the price so that we can have a sale.
Those are important questions. I think the idea is, how do we define something that is market leading? And I think there's been a confusion about the savings. The savings would be in reduced premium. So yes, there's a savings for employers, but would be a monthly savings for the employee that signed up for it. So kind of to tie into the sales, or the membership report that was the agenda item before us, as you look at different employer groups throughout the state who are looking for this more high deductible plan, this starts to give you something that would be in that area, but at the same time protecting the member, giving them choice, giving them so they can earn it back. So it starts to give a kind of a new model that is maintaining things, but engaging the member and the physician.
So I guess in those terms, in terms of this new PERS Select proposal would have a specific premium reduction, and we know what that'll be. And we know that some folks who elect that plan will benefit fully from those incentives, others won't. So do we know of that premium reduction, what part of that will we attribute, can we associate with the incentives, and what part of it can we attribute to going to a much higher deductible, and how much of that is known? I mean, I would think we know pretty much to the penny what the contribution to that premium reduction of going to high deductibles will be, just depending on participation. But I don't know that we know at all what, if any, contribution will come for those incentives. We have faith, we believe, and I think it's a good thing. But it seems like we're kind of saying, let's also raise the deductibles. I'm just not sure I understand that if they were two independent decisions, would we make them both on a financial basis?
Well, I like the idea that Leanna and actually Priya acknowledged that the VBID is separate and apart. The decision-making on the VBID is really separate and apart from anything related to care and choice. So I'd like to go back to the VBID.
I'm talking strictly about
The
PERS
VBID.
Select.
Yes.
The new PERS Select.
So we have run numbers in terms of this benefit design, this VBID benefit design package, because there are costs associated with lowering the deductible to $10. That has a tendency to raise premiums. There are costs associated with other aspects of this package in terms of keeping the, if using the incentives to keep a member, not only make them healthier, but keep them where they are. So we have run the numbers on these packages, and we can come back and show you next month where some of those details are in terms of the VBID. So, did that answer your question? I mean, can I?
Because I guess I'd like to know what would the impact on the premiums be of just doing the incentives without increasing the deductible, and kind of vice versa.
We can run this.
And just as a reminder, the goal is if we did vote in March to approve this, the rate development process and the premiums go from February to April. So negotiating premiums is a several-month process with the carrier during negotiations. So I think that some of them are projections, but typically the PPOs have done fairly well compared to some of the HMOs historically in premiums. But I don't think we could actually come back with a premium projection next month. We want to make sure that the rate development process is pristine in its own self. But what we can do is come back and give you the math on how we projected the overall savings to the system, and then maybe equate that on what that means to a member. Is that fair?
Yeah,
I just want to make
that's
sure
very
I clear that up. Okay.
Thank you. Mr. LaFaso.
Thank you, Mr. Chair. Just a quick follow-up. Do we have any experience of whether we've offered any of these programs on a purely voluntary basis and whether they've moved the needle? And I guess one other thing I'm not clear on is, do some of these programs actually require the tutelage of a primary care physician to work?
Okay. As an architect designing this for several years now, or 2 years, what I would really like to see happen is that members who enroll in this value-based insurance design in January, after they've enrolled, they do all the things they need to do to meet those 5 incentives. That would be so much easier to administer if everyone was incented to just, go in, press the button that you're a non-smoker, or tell the doc you're a non-smoker and have the doc or the health plan press the button. To me, the incentives, the engagement piece is really, if they select this plan, have it, do it all at once. So you already know early on in the year that you've got those 5 deductible incentives. So it is going to take some engagement by CalPERS and by the providers and through a good communication campaign to let our members know if they do this, they don't have to wait to see, am I going to have a surgery this year? They can just go in and certify in terms of having met the incentive pieces. And it is available for families as well.
I think as a follow-up comment, for the programs like Condition Care and Future Moms, we do have results that show that they're impactful, but the participation, particularly in Future Moms, tends to be lower, and we have data that shows that when an employer provides an incentive to participate, it does go up and the ROI increases, right? Because but it's hard to say, like, I'm going to give you a car seat when you're acting as a trust with multiple employers. And so that's why the idea is to waive that. If you participate, then you would have your co-insurance waived to try to have incentive for someone to participate in the program.
Thank you.
Okay, seeing no other requests to speak from the dais, we have 3 requests from the audience. Al Darby, Tim Behrens, and Stephanie Hueg. Please come forward. The microphones will be turned on for you. State your name and affiliation for the record, and you'll have up to 3 minutes for your comments.
Thank you, Mr. Chair, and congratulations on your new status.
Thank you.
And your co-chair. I'm Tim Behrens, president of the California State Retirees. We've reviewed the review's proposed increase in costs for Anthem Basic Plan members, that's combo families and pre-Medicare, as part of the VABID strategy for 2018. Although the increases in deductibles and other member out-of-pocket costs have been reduced from the initially proposed dramatic increases, we believe, in light of new information, no shift in cost burden to member is warranted at this time. The latest proposal would still increase PERS care deductibles by 50% and PERS Select by 100%, which disproportionately affects members in 18 rural counties and other locations where Anthem PPOs are the only health plan left available to members. In some cases, the newly proposed $1,500 and $2,000 per family may prevent some from following through with their needed care. And I think a couple of the members of this committee asked really the right question, and maybe we'll get a better answer than the one I'm about to give you. But it seems to me like if these proposed increases occur, an average retired stakeholder will be paying out of pocket at least 1 month of their retirement pay for the deductibles. So now I'm going to be living on 11 months retirement instead of 12 months retirement based on my information on this proposal. Some other things that I think need to be brought to your attention: since this proposal was introduced, the health insurance tax landscape has dramatically changed. With passage and signing of the Tax Reform Act, major corporations' federal taxes have been reduced from 35% to 21%, which means now they're going to make a profit of at least 15%. Each company will decide what they're going to do with these profits, but some of the percentage should surely go to reduce premiums and not just to the shareholders. It's important to note the tax breaks and profit increases to insurers will take place in 2018, thus affecting 2018 rates. Anthem has already adjusted for ACA markets, which were not as profitable to them by pulling out. So we fully expect CalPERS to have good leverage to have reductions in premiums without having to resort to charging members more to obtain their health care. We do support the health incentives for rebates in the VBID proposal and support efforts to control health care costs. We just think that you should leave our already high deductibles for basic plans alone. And I'm out of time, or I tell you some more stuff.
Thank you.
Hi, I'm Stephanie Hugh, California State Retirees. I shared with the board, I hope you got copies of Larry Woodson's statement, which reiterates a little bit of what Tim was talking about, the profit margins that have increased greatly with Anthem and United Healthcare. This presentation today is different than the presentation that we received at stakeholders the other day. The biggest difference that I noticed was to get the incentives, we have to call Anthem and say, yeah, I'm not a smoker. Yeah, I did a second opinion. You don't do that with your doctor. We suggested that they go do that with their doctor on their first doctor visit of the year, whenever that may occur. So this is a little bit different. The premiums, they're talking about PERS Select, yet all of a sudden the PERS Care premium goes up, or deductibles go up. So they mix the apples and the oranges. So that leads to the comment I heard, I believe, from Mr. Slayton, that they're leading us to go to PERS Select rather than just dealing with the rural communities. This also does not increase the number of physicians available in rural facilities in rural communities. So we're already have issues with patients not having availability of doctors. Now we're saying, well, not only do you have to go pick a primary care doctor, it doesn't exist. So how are they going to do that? There's no mechanism for it. PPOs already ask you to find a primary care doctor. So this is really not different. It just costs more. And for a retiree, I heard Mr. Jones say, you might be living on $3,000. Well, guess what? Look at $2,000. A lot of retirees live on less than $2,000. So this, to me, is not a very good idea. Thank you.
Thank you.
Al Darby, Vice President, Retired Public Employees Association. I echo the remarks of the other speakers. And there are potential administrative issues related to this VBID program. Disputes over whether all of the 5 requirements have been satisfied or not will be an issue. Most patients are pretty passive about getting things done that have to be done, and then they struggle at the end of the year to get it done. When they do it, then they'll be in the situation of trying to get co-pays refunded, deductibles refunded, and other costs that they may be entitled to that they did not receive by not having all of the requirements recorded. Medically unnecessary doctor visits may be required to solve these administrative problems. Patient care issues are complicated by whether you have an enrolled physician in this program. There may be none in the area that you're in. Passive verification of the 5 requirements could lead to deception and inaccuracy in the wellness program results. Initially, there was a program reduction to members in premium. That seems to be lost in this whole process, a significant decrease in premium. There are elements of education to VBID that must be produced by either CalPERS or Anthem. Otherwise, members are going to be uninformed on what the requirements are to meet the VBID requirements and get the full benefit of the discounts that come from that. And then the question is, how proactive will the doctor or the insurance company be in member compliance? Members are often apathetic and passive in completing these requirements. Thank you.
Thank you. Staff want to respond to any of the comments made there, please?
I'd like to start. So Stephanie was, one of the things that she said during stakeholders, she basically buys into keep it simple. And so one of the things that we wanted to make sure is when we look at the incentive is trying to keep it simple. specifically related to when you go see your doctor. If you do not have a chronic condition and you have no surgery, that is automatically a credit given to the deductible. The one thing that the member does have to do is they have to either call or they have to go online, and they simply click a button saying that they are a non-smoker. Anthem stated at the stakeholder meeting that they do not validate. That is on your own accord that you're doing, that you are a non-smoker. And then for the others, there is some interaction, obviously, for your physician. But I think it's a combination. And I part of this is, if it moves forward, it's really about communicating so that people know how to get the incentives to offset that, and it's as simple as possible. We don't want our member having to go to doctor's appointments and paying co-pays when they don't have to. So we believe it's fairly simple. There will be a lot of things that Anthem does automatically. Like I said, if you have no surgery that year, they automatically credit that. You automatically get that. There is no interaction on the member on that part. So we apologize if they felt like that we gave one piece of information at the stakeholder meeting, one here. But we were trying to clarify, but there is some confusion still about incentives, and we need to provide a much clearer roadmap on how to get each of those to maybe basically offset the deductibles, so the deductible ends up being the same amount that they're paying today.
Thank you.
I have just one more point to add to Leanna's comments. And yes, we did hear what the stakeholders were telling us about how do you keep it simple in terms of getting your 5 incentives. On page 405 of this agenda item, there is a table that we prepared, and we just didn't speak to it, and so apologies if we didn't convey that there are ways that that these don't involve the member. For example, with the biometric screening, once they go to the lab or once the kit is sent in and it's analyzed, that then becomes part of the record for the doctor. And if you look at this chart, the member action says annual biometric screening at the doctor's office, the lab, or in the home with a kit. And then automatically through the claims adjudication system, it is processed, and then the results made available to the primary care doctor. For the flu shot, for example, if they can't take the flu shot, if they do take the flu shot again, that goes through the claims system. So it's automatically recorded. If they do not, all they have to do is call the health plan and say, I can't take it, or tell the doctor to notify the health plan that they can't take the flu shot. Smoking cessation, that does require, and actually it's interesting how when you talk about going on the computer and clicking the button certifying yourself as a non-smoker, and talking to others about this, they say, well, if I saved $100 and if it's my dad who's having trouble, I'll just do it for him and walk him through it. And so that's you can either do it quick with a press of the button on the computer or through the physician or the health plan. Second opinion, again, because these are elective surgeries, they're often pre-certified in terms of scheduling through the PPO. And if you're pre-certified as for an elective surgery, you have the opportunity to obtain a second opinion. And that's actually, even without this, we have the WellV product. We encourage members to look at alternatives to care through the WellV product. And we actually have members not have surgery in terms of what they discovered on their own, what the benefits and risks are associated with having surgery or not surgery. Again, if there is surgery, it's done through the claims system, and the claims system will look for that second opinion through coding. And then the condition care management, I think Dr. Lohr explained that to you. They outreach to you. They ask you to engage. It's either through letter. I believe it's through letter. If you engage, then again, it's an automatic process. So apologies to the retirees if we did not point this out. We did hear them, and we did put this table in. We just didn't speak to it.
All right, thank you. Ms. Mother.
Thank you. Stephanie raised I think, an important point, and that is the availability of primary care physicians. And have we done an assessment of the adequacy of the availability throughout the network?
We did, and we feel that there's adequacy. In fact, there's multiple types of physicians that can be selected as a PCP. And I mean, I think we can't solve the issue through plan design on if you live in a county that has limited primary care doctors, but there's no, if they're in per select, they still would be on this VBID plan design doesn't limit any primary care doctor that's, it's the same, the select network is staying the same.
Yeah.
So there's no, the only thing that it does is actually if you select one, they know that you selected them, and you would be able to pay a lower copayment, but it doesn't remove any primary care doctors from the current select network.
So we looked both at how many primary care doctors there are, and also whether they have availability in their...
It's hard to look at availability, right? Because you could decide that as a primary care doctor in PPO, not HMO, that you're going to work 4 days a week, or you could get a health problem yourself, or different things like that. So availability does change by the physician's situation. But we looked at open panels, and we looked at availability. It's interesting because in HMO, you have you have that connection, and you know more about availability than in PPO. And I think that's what we're starting to be able to, once you know how many members someone has, then you can start looking at panel size and things like that. But we don't have that data when people are not selecting a PCP. So I think that if you approve this will actually help us start to get the kind of data to understand about PCP panel size in rural areas, and be able to maybe do something about or talk about that.
Okay.
I would like to point out the footnote on page 3 of 5 in the agenda item, and that is primary care. A lot of folks think that it's a family practitioner, a general practitioner, but there's actually 8 specialties that can serve as primary care: rheumatology, pulmonology, internal medicine, OBGYN, pediatrics, et cetera. So we are, though, to your point, Ms. Mather, we're looking at the rural areas. Not just what the physicians are, but what is the composition of the physicians. And we also think that perhaps that's why outreach to the physicians about this is important as well, to address making sure that maybe there's a physician not taking new patients, but maybe this would encourage them to take new patients because they're going to get a member who's engaged, who will do these things, and actually, it'd be more of a partnership than not, as it might be today.
Okay, thank you.
I was just going to say one more thing. When we think about, we've actually been putting a lot of thought into educating the providers, to Kathy's point, around population health and quality metrics and things like that, and looking at how do we do combined panels, how do we have WebExes to talk to them about these kind of quality metrics, and how to improve the workflow at your practices to help people make sure they get the flu shot, and talk to them about things like that. So I think there's a lot of opportunities about how do we both support the providers and the members in rural counties.
Ms. Taylor?
Yes, thank you. I just wanted to go on one of Stephanie's points as well. She said that and these PPOs, generally speaking, you have to have a primary care physician. Is that the case?
No, in PPO, you can choose to go to see a doctor or go and see a specialist. You don't select a PPO. That's one of the differences, that now you would select a primary care physician.
So
But that currently doesn't exist now.
It does not exist. So there's, okay.
And I guess I should clarify that in our, I think there's a way in the ACO where you could call and say, this is my doctor, but it's not really a set, but it's not part of a plan benefit design. So I think that
Right.
this is, you could let us know, like I usually see Dr. Smith, or we can see in our claim system that you usually see Dr. Smith, but it's not as part of the benefit design, right? This is
Right, but
different because
what I'm understanding is that she's required, wherever she goes, she's required to have a primary care physician. So whether or not it's part of the benefit design just mean, I don't know why.
Yeah, in PPO, Mrs. Taylor, you're not required to select a PCP currently in PPO.
Okay. And then I wanted to address the cost shift. I know we're raising it from, and I keep forgetting which one's which, from PERS Choice and PERS Select by $500 and $1,000. And then you get your incentives. I believe it was Mr. Behrens that brought up the fact that and I think even Mr. Miller brought it up, is it possible actuarially, and that's maybe where we need to explain this better, is it possible actuarially to start at $500 and $1,000 and then give the credit? Because it does appear initially that it is a cost shift to our members and would be most hurtful to our lower paid employees or our retirees who are on a fixed income. So I don't know. I know that this has changed. I know that it was much higher than it was originally. It was much higher than it is now. So I'm wondering, is that an option? Or because of all of these incentive copay reductions, is that not actuarially possible? And can we kind of explain that at our next meeting? And why that wouldn't work. And then additionally, I think it was brought up in both the letter and in Mr. Barron's statement, I don't believe the tax cut that these insurance that doesn't really have anything to do with our insurance, the risk pool, et cetera. That doesn't have anything to do with that. But what does concern me is on many occasions, as someone who has had, I've said this before, has had an HMO all my life, all my adult life, it doesn't seem to contain the costs like we say it will. So if we don't see that $46 million reduction, or even if we do see a $46 million reduction and we don't see a reduction to our members, as well as the employers, then I'm not sure that this is worth putting a cost shift onto our employees. And of course, we won't know that until we institute it. But that's where my concern lies, is because, on many occasions, we've, thought that these HMOs, as we do this or we do that, it should bring our costs down, and it doesn't seem to do that. We always have a cost increase.
What we can do is come back in March and model the financial aspects to this proposal in terms of whether you would, in terms of using, for example, if we're in the 2018 premiums, those are known. We can take a known premium and model it and show you some of the things you're asking for.
That would be
That's what I
great.
was thinking.
All right, thank you.
All right, seeing no other request, thank you. I think you heard quite a bit of questions and concerns today and stuff to bring back for the future. Anything else, Ms. Bailey-Crimmins?
Not on this agenda item.
All right, thank you. That brings us to agenda item 9, OptumRx Program Administration. Ms. Bailey-Crimmins.
Good morning, or it might be good afternoon by now.
Almost.
Leanna Bailey-Crimmins, CalPERS team member. Believe it or not, January marked the 1-year anniversary that we migrated to our new pharmacy benefit manager, OptumRx. And over the past 12 months, Optum has worked hard to overcome challenges. And you will see through today's report that there has been significant progress. But there's a quote that says, "Progress means getting nearer to the place you want to be." And the data will show progress, but I also want to put a disclaimer that OptumRx still has room for improvement. And CalPERS' team members meet at least weekly to address any member concerns. So today's information item highlights progress in 4 areas, which we actually covered in November. The first was customer service, because the member is at the heart of everything that we do.
I didn't do it.
The second is prior authorizations. We wanted to look at system and process improvements. There was significant spike, and so we wanted to make sure we looked at that. I will be providing an update in that area. The Medicare formulary. The retirees had asked for us to compare the 2016 CVS Caremark formulary against the current 2018 OptumRx formulary, and do a comparison, because their question was, can we go back to the CVS formulary? So we will provide you update today. And then lastly is on technology. Technology is a face of an organization, and when OptumRx systems fail, our members can't log on to the web portal to do refills, see what's going on with their mail orders, and so there have been improvements made on the technology, not on just availability, but also there's been enhancements into the system that I'd like to cover with you today as well. So for customer service, we're pleased to report as of January of 2018 that the CalPERS customer service satisfaction rating, specifically for the OptumRx call center, is 94%. They collect this by doing post surveys with all the members that call, and we are currently in the 90th percentile, which is good. Always still can get better. And then one metric we pay close attention to is the call transfer rates. And the reason this is it basically measures how often our members get the information on the first point of contact, and versus having to be escalated to a lead or a supervisor. And so over the past 7 months, we have seen CalPERS call transfer rate go from 10% to 2.5%, which means our members are more likely to get their answer the first time around, which is extremely important. We also want our members to get the right answer the first time. And so we had asked, and Optum delivered an Adopt a Member advocacy program. So if one of our members calls multiple times about the same concern that has not been addressed, Optum will automatically escalate that call to an advocate who will research and actually resolve this, because the last thing we want is multiple members calling multiple times. So that's been improved. And then I also want to thank the Retiree Association, because of their request and then ultimately our fulfillment, now Optum has a dedicated team that specializes in Medicare. Anybody who's ever dealt with Medicare, there's a lot of intricacies with Medicare. And so if a Medicare member basically self-identifies, says, I'm a Medicare member, they basically get transferred straight to that team. Someone understands those nuances and also understands the CalPERS EGWIP program. So I think that's extremely important. And prior authorizations. Prior authorizations are not inherently bad. I think sometimes we think they are, but they are usually clinically driven. If there's a narcotic, an opioid, they must be cleared through a prior authorization. Also, they can be benefit design required. But a few months back, again, our stakeholders spoke and we listened and we looked at the data and we saw a significant spike in prior authorizations and also a high overturn rate. And why the high overturn rate was something we were paying attention to is a prior authorization comes into the system, it's appealed, and if that appeal is overturned, then basically it tells me that the member potentially went through a bunch of extra steps and hoops that they shouldn't have had to go through. So we researched and found 3 areas that were causing this huge spike. One is CMS requires a 72-hour, they have a 72-hour denial requirement. So basically, if a Medicare member was putting in their prior authorizations on Thursday or Friday, because CMS actually uses the calendar week, not the business week, the clock is still ticking on Saturday and Sunday, even though no one's there processing it. Then Monday morning, there's an automatic denial, and now a member has to go through an appeal process. So because I've been working with the stakeholders, getting communication out, a lot of our retirees are now focusing on getting their prior auths in either Monday, Tuesday, or Wednesday, so we meet that 72-hour window. So you'll see that the denial rates have really gone down. The other was lack of information. There was a lot of denials because the prescribers weren't, which the member doesn't know that, but the prescriber was submitting basically incomplete prescriptions. And so we've done quite a bit into improving that. And then also EGWP improvements. We talked about this early on. When you're on Medicare or you're 85 years old and you've been on the same medication for 20 years, unless CMS is requiring it, why are we messing with it? So we have put a lot in place in that area as well. So improvements made has been proactive. So 30 days prior to a prior authorization expiring, Optum actually is proactive and reaches out to the prescriber and tries to extend that and without any member interaction. And I have to say that at this point, the data shows 98% of the prior authorizations are being renewed without any member action, which is positive. Also, because we have the system in and we're reaching out to prescribers, the lack of information denials have gone down significantly because now they're having this dialogue that necessarily they weren't having before. Call agents now have a prior authorization decision tree. We want to make sure that our members are getting consistent and accurate information, and so they now have that available. So, over the past year, prior authorizations, I know our focus has been on EGWP and Medicare, but we wanted to show our actives as well. So basic approval rates have increased from 53% to 77%, and for EGWP approval rates have gone from 45% to 84%. So for Medicare prior authorizations, we have also directed OptumRx to use only the CMS guidelines. So this means basically it streamlined the process requirements, and unless CMS requires it, it should be approved. Now I will do a disclaimer. That does not mean that prior authorizations won't occur, but it just means that it is going to be CMS directed. So for the formulary improvements, there have been significant changes. For example, there was a whole list, I think, that went out to our retiree stakeholder groups and to you as well, but I just want to give a quick little snippet of some of the formulary improvements. For HIV and transplant medications, they were removed from specialty pharmacy and added to the maintenance and medication, and are available at any network pharmacy, which is obviously increasing the convenience for our members. All Tier 2 and 3 generic drugs were now down-tiered to Tier 1, which means it's costing our members less. And then for drugs excluded from a formulary, this is where you're kind of reaching on more of new medications that just haven't been added. Members can now request a medical necessary review of the benefit, and which now allows us to see if we want to add that to the formulary. So when CalPERS compared OptumRx's Medicare formulary against the CVS Caremark, we found 2,000 differences. 63% of those differences were positive. Optum has 581 more drugs than CVS Caremark, and 395 of those are a lower cost. So I still have to look at what the difference between the other ones for the lower cost. And then other area for improvement is 30% of the changes showed that CVS Caremark actually had more drugs with less restrictions. So this is an area we will be working on again, trying to make it easier for our members. So there's still work to be done on the formulary. CalPERS projected to save both members' monthly premium cost and save the overall system $63 million. In the first year of the contract. In 2017, CalPERS actually saved $68 million. And for OptumRx, specifically for our members, PPO Medicare members save $50.58 on their monthly premiums by going to OptumRx. PPO Basic members save $14.31 on their monthly premiums by going to Optum. Now, HMO spent $1.23 up more, but what we were seeing in the CVS Caremark trend, it was actually even going up higher, and so we actually somewhat plateaued it. So that was obviously a very positive outcome. And then technology. We know technology directly affects our customer service. And so there was a large outage Optum had in September 2017, and they have done quite a few steps in bringing that uptime so that when our customers log in, that it can be reliable. And then in addition to reliability, over the past several months, they've done 3 things. Now they have real-time monitoring, so if a call is getting to 15 minutes, it's automatically flagged, and a supervisor is then working with the agent to see if they need to interact or to intervene to ensure that that resolution occurs, and that happens in a timely manner. Also, we have real-time chat for prior authorizations so that there's real-time inquiries and updates, which is very helpful if anybody's ever used a chat feature. And as of January 1st, Optum implemented a virtual hold. Time means a lot to a lot of folks, and so where a member wants to have an option of basically leaving their information and having an agent call them back, that is now available. So in conclusion, CalPERS continues to work with OptumRx to identify changes that will improve member experience. And the CalPERS Health Plan Member Survey went out, and as a reminder, it includes questions about satisfaction of our pharmacy benefits. So once we receive the 2017 results, CalPERS team members will be comparing that against the 2016, which we had CVS Caremark, and we will be bringing those results back to you. The goal is to provide the PHBC another update in June. Thank you, Mr. Chair. This concludes my presentation, and I'd be happy to answer any questions.
Thank you. Thanks for the presentation. Mr. Miller.
Just a question. Early on, prior to my time on the board, there seemed to be a real outcry about customer service from OptumRx, and I see steps are being taken and looks like things are improving. But what's being done in terms of service recovery for all those folks who were so unhappy early on, who may have just kind of disengaged with us at some point?
I will check with Optum on that, but I do know, at least at this point, normally when you're dealing with medication, it's not just a one-time, it's an ongoing relationship with the PBM, and we are at 94%, but I can see if they've gone out and proactively looked at anybody that was unhappy and gave them an unsatisfactory rating and what they're doing to improve that. Thank you.
Thank you. Seeing no other requests, I have 2 requests from the public. James Anderson, Donna Snodgrass. Please come forward, state your name for the record and your affiliation, and you'll have up to 3 minutes for your presentation.
Thank you, Mr. Chair. I want to request more than 3 minutes, please, so that I can read excerpts from the package that you have in front of you.
Well, we already have the package in front of
Yes.
us, so let's not take too long. We're very late today.
Okay. Donna Snodgrass, Director of Health Benefits for Retired Public Employees Association. Because of the continuing and unresolved issues of our members' experience with OptumRx, the Board of Directors of the Retired Public Employees Association of California unanimously supported a vote of no confidence in OptumRx and this PBM contract. For over a year, we have had meetings, discussions, promises, and were made for improvement, and we now have no hope that the improvements will be made. To continue to handle each situation as it arises is no longer acceptable response. The RPEA members who have asked for assistance are not all covered by CalPERS medical plan. This indicates that the problems are not unique to CalPERS contract agencies. OptumRx has a system-wide problem of properly servicing their clients, not just CalPERS. RPEA is publicly requesting that CalPERS begin the steps to end the Optum contract and provide a PBM that has the experience and the will to service the members who rely on their primary benefits. A member from Gig Harbor, Washington, writes to us and says, during the course of several phone calls to the Optum call center, I had a conversation with a very nice representative. During the call, the rep apologized to him for the inconvenience and time it had taken to resolve an issue that he had. He was told, it's not you, it's us. Optum has taken on more than we can handle. We are spread too thin. We have taken on Kayak as a client, and personnel have been diverted to the Kayak account. a member from Redding, California. In December, it escalated extremely. A new prescription was written for her husband who has dementia, and Optum refused to fill it because they had no record of the, this is emotional for me, sorry, no record of the durable power of attorney that was required for her to take care of him, and he was in a care facility. The representative of the care facility, his primary physician, and herself had several conversations to no resolve. They insisted they did not have the power of attorney, and it had been sent a month and a half earlier. She says, "I find this service to be very irresponsible, inconsistent, and very confusing." Sierra Vista, Arizona. A medication, diclofenac sodium. She had been on that medication for years for rheumatoid arthritis. When she received the package from Optum with the abridged formulary list, that medication had been moved from Tier 1 to Tier 3. With a phone call to Optum, they said, "We don't know why it was moved." A supervisor called back a couple days later and said that because CMS was moving diclofenac sodium, potassium, I'm getting them backwards, that the sodium was just put into Tier 3 to match CMS. And I'd like to point out, and the abridged is in there to show you in Tier 3, but in the other two lists for the formularies, that drug is in Tier 1. They did offer to send her a partial waiver of premium, which would have taken it to $70 instead of $10. Scotts Valley, California. This member is still waiting for a prescription to be approved. It was actually denied because it took place over the Christmas holidays. He was on a mega antibiotic because of an infection due to a massive hematoma that occurred. The doctor could not reach Optum for the prior authorization. Long story short, they filled it at CVS for $814. On December 29th, they tried again to get approval on January 2nd, and Optum's supervisor told them it was too late. A new year had begun. The process had to be started anew. I'll finish with that. There's others in the packet. Please read the entire package that I supplied to you.
Thank you.
Mr. President, members of the board, I'm James Anderson. I'm the legislative director of RPEA, the Retired Public Employees Association. I'm asked to add some things that Ms. Snodgrass covered because we had a new issue that came in by fax yesterday. Apparently, Optum has disenrolled one of our members from Medicare Part D. They sent a letter last year asking for detailed information about their address. Why a cold call, a cold letter to a member asking for an address change when the member's a member of CalPERS, they have the addresses, and things work out. I've made changes to my address. CalPERS warrant didn't come because CalPERS had made an error in the address. When the warrant doesn't show up, you get very interested. This member didn't respond to the letter because it was a potential scam. I got a phone call from Optum asking for detailed information, my Social Security. I hung up on him. I was told Optum does not make cold calls. Eventually, this thing progressed over the last year, and in December, Optum, on their own effort, canceled Part D. The member cannot get their prescriptions. There is penalties for not having Part D under Medicare. It seemed like if that was going to be disenrolled, it would be up to CalPERS to disenroll them, not Optum on their own initiative. So we haven't investigated this in detail because it just came in yesterday, but we will investigate it. We hope someone from CalPERS can assist us with this and get these people back on their proper medication.
Please share that information with our staff and make sure it's taken care of. Thank you. All right. Ms. Bailey-Krim, is there anything in response?
Obviously, we would love to investigate. One is they shouldn't be cold calling. Two is Optum does not have the authority to disenroll one of our members from Part D, so we will get to the bottom of that. And as for Donna Snodgrass's comments, we take any time an escalation that it is sent to us, we take it with the utmost. It's the highest priority. We get right on it. We look at phone calls. We look at the data. We make sure that the member is taken care of. I don't believe I have personally access to all that information, but I think Donna has recently shared it with Dr. Sun, so I will be looking at that personally and getting to the bottom of what is going on with those specific members.
Great, thank you.
Thanks.
Seeing nothing else on this item, item 10, pharmacy pricing strategies. Ms. Donaldson.
Good afternoon, Mr. Chair and members of the committee. Last month at the offsite, we had a panel present pharmacy strategies, and we talked about the complexity of managing pharmacy programs. This item brings forward some of the things that we have started working on and will be working on throughout the next year, in addition to providing some future strategies that we want you to think about. So, moving on, the 2018 and 19 pricing strategies that we are considering and we want to bring forward to you. Some we have already begun and some we're thinking about. I want to talk about the California Pharmaceutical Collaborative. This is a collaborative of multiple state agencies working together to explore direct purchasing from the manufacturer, certain specific and high-cost drugs such as hepatitis C. And the collaborative includes both general services, our sister agency, Covered California. It includes Department of Public Health, Department of Healthcare Services, the California Veterans Association, Department of Corrections. So collectively, we represent a significant number of not just state employees, but Californians. And so that is one of the things that we started working on this last year and will carry forward. We have a pilot that we're getting ready to launch in terms of academic detailing, and that is where pharmacists go out to our provider groups to educate physicians about the formulary, and which many of the physicians do not understand what the financial burden is to their patients. So we have been trying to do something in academic detailing since Dr. George Deere was on this panel, and we finally have the opportunity to launch a pilot. We're also looking at a potential pilot for reference-based contracting with select drugs. This is a concept that's coming forward in the industry, that you work with the manufacturers, or through the PBM, you work with the manufacturers to identify a drug, and if the manufacturer is willing to value-based contract, if the drug doesn't work, you're actually paid back. So that's one of the items that we're looking at. In terms of adding numerical tiers, we have currently generic, preferred brand and non-preferred brand. It's easier systematically to go to a numbering system, but all that means is instead of using a descriptor, you're using a number. So when you hear tier 1, tier 2, tier 3, that's the design that we've been working with for at least 2 decades. We also want to look at a reference-based price approach by therapeutic class. There are 70 therapeutic classes. Just as we would not take on every reference price for a medical procedure, we don't wish to take on 70 therapeutic classes. But we do, as we did with hips and knees and arthroscopies and colonoscopies and all the things we did reference price. We want to be thoughtful in terms of exploring the opportunity to reference price by therapeutic class. It's similar to a member pays the difference, except that it looks across the class and it looks based on evidence, recommended pharmaceuticals within that class. So that's another opportunity that we are exploring. For 2019, as I described to you in terms of how do you deal with the cost of high-priced specialty drugs, the ICER approach was something that we presented in July, which is the Institute for Clinical Economics. And this little flow chart was presented by James Robinson, in which it looks at a reference pricing approach as well as a value-based purchasing approach. We would look at evidence-based value in terms of specialty drugs, and that's something we'll continue to explore through next year. And again, many of these activities, if we're working on it in 18, we would try to have it ready to go in 19. If we're working on it in 19, we try to have it ready to go in 2020. So we're always a year ahead in terms of exploring these options for improved benefit designs. In terms of the future, we have one of the ideas that's coming out of the industry now relates to carving out the formulary so that you have a standard formulary, and if it would be managed by a separate company, and then if you do have to change PBMs, the formulary is already being managed. So that is something we would look at for 2020 and potential implementation in 2021. Finally, on page 4 or 5 of your agenda item, we still face many of the challenges that the panel presented in July, and this is just a list that we call continued seeking solutions. The pharmacy benefits programs are complicated, and it's one of the most complicated industries, and that even beats long-term care. It is one of the most complicated industries that I've ever had to work in, and I actually had to learn. And so, anyway, that concludes my presentation. I'm happy to take questions.
Thank you. Seeing none, we will move on to agenda item 11, summary of committee direction. Ms. Bailey-Crimmins.
Mr. Chair, I documented, this is a very robust conversation that we had today, so I have 3, and I also have a few operational ones that had come up. So first is we want to bring back a high deductible, low cost research to the committee, looking at cost to system, cost to members, and then making sure that we're looking at that from 2 lenses, both retirees and actives. The second was Mr. Jones is related to the sponsoring agencies, and we focus on the pension side. But once someone leaves the system, what the impact would be to actives and retirees. So there was a request for us to show some analysis in relation to that. Did I capture that correctly? Okay. And then 3, a lot of on the VBID. So bring back. VBID, basically the savings. We want to what is the savings? Where is it going? A lot of information related to that. Also, the per select, specifically related to the actuary possibility. So if without any deductible increases, what that would look like. So really about the alternatives on that. And that was what I captured. Mr. Chair, was there anything else that I potentially missed?
I think that's good.
Okay.
Thank you. Brings us to item 12, public comment. Anyone from the public that wishes to address the board at the committee at this time? Seeing none, then we are going to adjourn the open session. We will go into closed session in 5 minutes. So we'll start closed session at 12 o'clock. Thank you.